Ladies and gentlemen, please take your seats. Our program will begin in 5 minutes. Please take your seats. Our program will begin in 5 minutes. Thank you. Ladies and gentlemen, please take your seats. Our program will begin in 1 minute. As a courtesy to others, please turn off cell phones and any other thing that makes noise. Thank you. Ladies and gentlemen, please welcome Cara James.
Good morning. Welcome to all of you to day 2 of the CMS Quality Conference. It is great to see so many of you here. You are clearly the early birds, and we welcome you. Before we really get into recapping, I'd like to take a moment just to show a little bit of a video of what we saw yesterday.
This means that for the first time that we'll be measuring patients' functional status, cognitive status, falls, pressure ulcers, discharge to community, readmissions, resource use in the same way across all settings.
That's why I'm very pleased to announce today that later this week, CMCS is going to publish in the Federal Register a final regulation that establishes a substantially enhanced 90% matching rate for eligibility and enrollment systems that are geared at supporting states' efforts at enrolling people in Medicaid and CHIP coverage simply, seamlessly, and with minimal consumer burden.
Well, definitely with Dr. Aurora's presentation, I think that just the insight he gave and how we can use limited resources to really work into our communities and strengthen partnerships, I think that was one of the most inspiring and inspirational things that I can take back.
We're very much aware that the work requires us to reach so many more people, and there's not enough resource to do it without combining and partnering effectively.
The next step requires your innovation, all your capabilities, your focus and commitment to quality, and your willingness and ability to measure and be accountable like never before.
And finally, it's important to acknowledge that transformation of our healthcare system is leadership work. All of you in this room are leaders for this country in improving the quality of care for patients and families. And so in this role, we expect a few things of you. We expect you to set bold aims that are beyond your immediate reach, and to achieve these aims by enrolling others in the work and partnering with one another and with other stakeholders who may not be here today, and that you enroll others in this work by making very specific requests and offers, and that you secure commitments from each other to work together in specific ways that will generate results.
So that was just a snippet of what happened yesterday, and I presentations, many of which the rooms were packed, and we'll talk a little bit about that. And some of the video you heard some of your colleagues and friends who gave their comments, but also we followed what was going on with social media. And as you can see, people felt like, so many fantastic talks and focusing on the power of partnership and transforming healthcare. I wish I could attend them all. I shared that sentiment. And I think, one of the other things as we're looking towards our bold aims of improving quality, that we remember that the patient is really what we're focused on, and making sure that we are giving them the best health that they can. It's all about the patient. So as we recap the day, we're going forward and looking at, we started with some of our successes. And so just yesterday, as we heard mentioned, we released the newest data that showed that 87,000 lives have been saved and nearly 20 billion from 2010 to 2014 in terms of hospital-acquired infection reductions. It's huge, yes, worthy of clapping. We continue to support transformation, and yesterday announced $110 million awarded to ESRD funding for the 18 networks to improve quality of care and continue focusing on access to care for people living with ESRDs. And already we've seen success in which the ESRD networks have reduced long-term catheter use by 11% from baseline. And the ESRD Network's immunization pilot project has showed major improvement in Hep B vaccinations by 243% over baseline, and PPV vaccinations of 310% over baseline. It's worthy of taking a moment because this is hard work, as you all know, and we are so grateful that you continue to come every day and to work towards the goals that we're trying to achieve. So as we look at the mountain ahead of us, it's great to look at how far we've come getting to that first level of base camp. And so again, you are worthy of success, and congratulations, and we thank you for your efforts. We also heard a really exciting presentation from Dr. Aurora, and we put this up because Dr. Aurora was the #1 trending tweet yesterday. And so very popular in terms of Project Echo and the work that they're doing, really transforming, building those partnerships, and driving results. And when you think about the work that he's doing to ensure that people in underserved communities have access to critically needed services, I think we saw so many things that really provided a foundation for the work that we're doing and how we talk about what we're looking at. So, and who maybe have had your coffee already, Does anyone remember what the #1 challenge in retaining good rural practitioner was? No Starbucks? I can say if there wasn't a Starbucks downstairs this morning, I might not be as peppy as I am now, but definitely, the lack of opportunity for a work-learning balance. And I think that that is also part of what this conference provides, is an opportunity to learn from your colleagues and from your peers, but also to hear how we get that balance in struggling and sharing some of our experiences, our successes, our challenges, and how we can overcome those to achieve the goals that we're setting forward. Dr. Aurora also talked about the ECHO methodology, using technology to leverage experience. Technology, data, the importance of understanding where we have challenges and measuring our progress. The main goals of what we're trying to do here today: build partnerships, share knowledge, and continue to drive towards success. Case-based learning to max our complexity, and web-based database to monitor outcomes. I think these are all great building blocks of what we can do as we move forward. There was a lot of interest in the Medicaid and CHIP conference yesterday, the seminar that happened, the mini plenary right after the plenary. And as you can see, this was standing room or sitting room outside of the room, where the room was packed and they put chairs all throughout. Might have been a fire hazard, but it's okay. We left an aisle there so people could get in and out. But great interest, and as we think about where we are, and you heard from Vicki earlier in the morning, it's worth noting and again remembering that this is the 50th anniversary of Medicaid and the 18th anniversary of CHIP, which now see more than 72 million individuals receiving coverage from these programs. Many of our vulnerable populations who would not otherwise have access to quality care. And CMS is looking, as you can see, with the voluntary quality measurement program for children and adults on a set of core quality measures. Already we have 51 states voluntarily reported a median of 16 child measures. 34 states reported a median of 16.5 adult measures, continuing to monitor that progress. In looking at some of the other grant programs that they discussed, we saw that health systems were able to extract quality metrics, implement QI programs, and improve on all 8 quality metrics. And as I was thinking about our colleague Gigi Rainey, who said, we look at what we're trying to do is really encourage people to boldly go where no man has gone before. And as she said, doing it on a bit of a limited budget compared to the Starship Enterprise. But it's that we're looking at again and still moving towards, as we now serve more than 72 million individuals in these programs, how do we continue to ensure they have access to high quality care and the ultimate improved population health. We also heard yesterday a focus on achieving health equity, something near and dear to my heart. The acting administrator Slavitt said, we need to improve quality for everyone, but we also need to close the gaps between those at the top and those at the bottom. As you know, eliminating disparities is a foundational principle of the CMS quality strategy, and reducing disparities is woven throughout the QIO 11th scope of work. We also saw the Partnership for Patients with a number of the hospital engagement networks focusing on reducing quality disparities, and it continues to grow in its importance as we think about disparities for those who are low income, racial and ethnic minorities, gender minorities, people with disabilities, and those living in rural communities. This year's conference, we see more sessions that are focused on disparities, but something that I was even more pleased to see is in a number of sessions that were not specific to disparities, it came up. How do we stratify data to understand where we have gaps? How do we address these issues? We saw in the Medicaid session yesterday, Pennsylvania mentioned that they've been stratifying data for over 10 years and working with plans and providers to set specific goals on how they can improve quality and reduce disparities. And I think we'd love to see more of that, because really health equity is in everything that we do. When we think about our path to equity here at CMS, we have a very simple USA principle. We want to make sure that we understand and address, create awareness for the disparities and their causes, that we develop and disseminate solutions, again, part of the sharing of best practices of what we're talking about today, and that we implement sustainable actions to move towards those goals. So that's a lot of what we see, and it fits a lot with what we've heard as well in some of the remarks that Dennis made earlier yesterday in the work that we're doing on quality, and as we're driving towards, as Dr. Aurora's framework about the importance of data and lessons learned. Today we have a couple more sessions that are focusing on health equity, in which if you want to learn about the CMS Equity Plan that was just released in September and what we're doing towards that. Some of you saw a preview of our Mapping Medicare Disparities tool yesterday. We also have a focus in our patient and family engagement track on coverage to care and some of the resources to help individuals understand their coverage and be able to connect to care. So as we leave in action and remembering what the focus of the conference is today, of building partnerships, we encourage you to build sustainable relationships with unlikely partners across silos. In this quote from one of the Medicaid grantee reflections, so it's kind of building relationships in what I would say is the key part of sustainability. And it's for the next project, the next grant that comes down the road, that you have a relationship, so to speak, in place that is offered that opportunity to build those kinds of bridges that may not naturally occur because the type of siloed work we often end up doing. This was also a charge you heard yesterday and some of the plenaries of thinking about as we look across all of our quality programs, which focus on unique populations in many cases, or unique conditions and diseases, that to get that multiplier effect that Dr. Aurora talked about, we really do need to partner across the sectors with some of our more unusual partners to really drive towards those goals that we're looking for. And I would also leave you, and so going back to what Administrator Slavitt said, I'm asking every health plan, hospital, and physician practice to ensure your contract language, training materials, data, and practices are aligned to achieve health equity. And I would encourage you to start by using your data to understand disparities if you don't already know where they exist, to identify your priorities in terms of where you have some of the largest gaps, and to set specific health equity goals to develop action plans to achieve your aim. We can get there, and it will take all of us working together. So as we tee up what's next in terms of today, we have a session on our patient-centered focus. And the woman here is one of the focuses that I keep in the work that I do. Since Patrick showed his children yesterday, I thought I would take a moment and show my 91-year-old grandmother. Oh, if I'm nodding my head too much or talking too much. But she also has a number of health conditions that keep us very well tied to the healthcare system. She's a 26-year-old veteran of Medicare and has a lot of experience, and so it's her and making sure that she receives the high-quality care that she deserves that keeps me centered. And I hope that each of you have someone like her in your mind as you're doing the work to keep you motivated on those days when it seems tough and you're wondering, why are we doing this? So I encourage you to keep going, building those partnerships, and together we can get to those goals and boldly set those aims and achieve them. Thank you.
We are here in a hospital, in your office,
in my office,
where I am your patient.
where I have many patients.
I came here today for a checkup, to check in with the hope you can help me feel better.
I come here every day to make people feel better, for checkups, to check in with the nurses and patients I care for.
I came here for answers about my illness and pain. I'm afraid of what you might find, afraid you may not find an answer.
It is my job to find answers. I went to school for much of my life in order to care for yours. It is my job.
We are here in a hospital, in your office,
in my office,
where I am your patient.
where I have many patients.
I am more than my cells, more than my chart can tell. I have a wife and children, 4 grandchildren. Please see me.
I have a family too, people I care for, but I am here to care for you.
The hospital is large, full of people waiting for their sickness to be named.
Yes, I remember you, though often I am tired. I leave for work too early and get home too late. I have a long list of patients to see and not enough hours in the day. I'm not a god.
Please see me. Everyone hurries here. I am afraid to ask a question, or I forget my question and then you are gone. I need to know what might be wrong.
Please talk to me. I want to have the answers. I studied years for this. I learned the names of every bone and muscle, of diseases, and how to treat them.
I am not a doctor. The names of pills and procedures sound foreign to me. But this is my body. What will this medicine do to me? How much do I owe per pill, per minute of your time? Please see me.
I read your chart, your family history, but I need your help to understand what paper cannot tell.
Please help me. I want to be healthy, but I need to know that I can trust you.
Please don't be afraid. Talk honestly to me. You are my patient.
Please listen to my story carefully. Care for me.
I want to hear your story, to care for you.
Help me understand. Give me the tools I need to be healthy,
to help you stay healthy,
to be a partner in my care.
to be a partner in your care.
Please see me. I am your patient.
You are my patient.
I am here with you, a patient,
a doctor,
a person in your office.
in the hospital,
We are working to get better.
to be better.
We are working, patient and doctor together. Please see me.
Good morning. Welcome to this on person and family engagement. First, we'd like to thank Metastar for granting permission for us to show that very compelling enactment of what's going on in our heads as we think about patient and family engagement, and as we think about how we can interact with one another. Before we get started, I just want to ask you to take a few minutes and find 2 or 3 people in your area and really talk about what most resonated with you from that video and how it might apply to the work that you do. I think when Dennis Wagner came yesterday, he gave the long list of everybody that's in the room. So we know that you do different work, but you all contribute to the well-being of our families and our patients that are in the audience and around the country. So how does it resonate with you, and how might it apply to the work that you do? Just take a few minutes and then we'll get a few responses from the audience. No. See, here's the new run of show. So I present and then my slides, and then Janine will come up with her slides, and then we'll have the panel come up.
Okay.
Yeah, that's, I'm sorry.
So you'll bring.
I'll bring up
This
Janine.
is where we are right now.
Yeah, it did change a bit. It just, we flipped. So Janine's going to come up after me. And she has a
So you introduced Janine.
right, and then that other side. Yeah, sorry about that.
Give me when you're ready to go back. I'll be right here. Give me a thumbs up and I'll.
I'm getting ready to go back now.
Okay.
Okay, I think if I could get your attention, there's obviously a lot that came to your mind when you saw that video. So I'm going to ask a few people to just share with us what your thoughts are, and hopefully we have someone with a microphone. Here we have someone with a microphone here and here about this topic and about how it applies to your work. Who would like to share something with us? Right in the back there. Thank you.
Good morning. My name is Jim Turpin. I'm with the TMF Quinn, and I work on the medication safety portion of the 11th scope of work. And the thing that really struck me was the communication between the patient, the physician on medication safety. I think we can, and also with the physician on teach-back on medications. I think patients typically are dispensed medications, have no idea what they're for, how to use them, which results in adverse drug events, getting that patient back in the hospital. So we can help those physicians communicate better. We can also help the patient become a better advocate on why they're taking those medications. Thank you.
Great, thank you. Anyone else? It's hard to see, okay.
Good morning, I'm Jean Fleming with HCDI, one of the SANs, and I really liked how the voices were blended. There were certain times throughout that they were both saying the same thing, and how often the patient and the physician are both feeling, you know, kind of vulnerable and uneducated maybe about each other, but they were saying the same thing, and that was just really powerful. I liked how that blending, because it really sometimes we're talking to each other rather than talking, you know, we're talking to each other rather than really listening, so that active listening.
Thanks. Yeah, the power of listening can never be overstated. Thank you for that comment. Anyone else? Yes.
So we had an interesting discussion around this. My name is Paul. I'm from Iowa. We were intrigued by the challenge of seeing each other, the important role of empathy in that dyad relationship, and how important it is for us in our organizational work and an effort to improve systems to recognize that we're trying to support that relationship in meeting the challenge of seeing each other as both sides of a therapeutic team.
Excellent, thank you. That's actually a great lead-in to what I want to talk about, and I know there's some more that have some comments. We're going to have some time at the end. Bring some panelists up shortly that can help contribute to this discussion. But you mentioned the systems and really looking at how we incorporate or integrate our concepts of patient and family engagement into what we do on a day-to-day basis. And that's what I want to talk to you for a few minutes about, kind of the journey that we've had at CMS in really embracing the topic and working through it. And I'm going to use some words interchangeably here, so don't trip up over the words. You know, we have hours of discussions on words, whether it's person and family engagement, patient and family engagement. We're all people, at least most of us are people, and and at some point we are potential patients or patients. At some points in our lives we're consumers. At some points we're serving as the family representative or the caregiver. So, you know, it's going to vary at where you are at any given time, which one of those roles you're going to play. So I'm going to use all of those terms as I talk. But I'm calling it a journey because it takes a while for an organization to really fully embrace all of the things that it means to have a culture of patient and family engagement. And at CMS, we really began this journey a couple years ago, and we're still on it and still have a lot of work to do. But the first thing you want to do as you're looking at your own program, your own work, or your own effort is you want to assess your organization to be effective. You have to consider your mission, your purpose, your culture, your structure, the desired outcome, and what it is and how you're going to integrate this into your conversation with someone out in the hall, and we were saying a project. This is not a project, believe me. This is a way of being. It is a way of working on a day-to-day basis. So even Dr. Aurora yesterday, when he was talking about treating hundreds of thousands of patients, he never lost the sense of individuality and how you meet the needs of the patients, their socioeconomic challenges that they have, the cultural challenges that they have. So along the way, regardless of the volume, it's still an important factor. So at CMS, we began to look to do our assessment. What is it that we do, and how can we really contribute and ensure that it's a part of the fiber of our being as we go about doing our work? So when we look at what CMS develop policies and programs, primarily those that come down to us from our legislative and administrative bodies. They then hand it off to CMS to implement, and within those guidelines, we have to establish those policies and programs. But even within that, we can consider the importance of person and family engagement. What else do we do? So we support beneficiaries and providers as they make choices about treatment. And so we have to look at the programs that we have in that area. We also make payment. We pay for health care. And so we look at it in that context. And then we acknowledge that there is an important role for families and caregivers. So what do we do in that arena? So I want to just spend a minute looking at those four things when we begin to consider. First, we have the CMS quality strategy. So you have to have some roadmap to how you go. Once you decide what it is that you want to do, what is your strategy? We just released, as Kate Goodrich mentioned on yesterday, and then there was a session on this, the update to the CMS quality strategy. I just saw a headline this morning. We released it, I guess, the Wednesday before Thanksgiving. It wasn't intentional. We just released it when it was ready to be released. And the headline is, "This is what CMS is dishing up for Thanksgiving." And Patrick, who is very quick, responded, "It's better than stuffing." So. So take a look at the quality strategy, and you can see, but it's a very specific role that we have in there for patient and family engagement. We then need a tactical approach to our strategy, and with that we developed the CMS Affinity Group on Person and Family Engagement. I'm going to talk a little bit about that. We also, we deploy, we developed, we institute quality measurement. And many of the measures that we develop and use in our programs are intended to measure the process or the outcome or even the structure in some cases in which patients have to receive care. But really, we will admit, up until about a year ago, we did not have a strong patient voice into the measurement process. But to the credit of those that work in measurement and Center for Clinical Standards and Quality, they made sure that any of the partners that work with us under contract that develop measures now have to have some mechanism of including the patient's voice in our measures development process. We also do many focus groups. We have patients in the room when we talk about actions. We have patients in the room today. And we also is a challenge for us, and maybe you have some good ideas. When we put a regulation out, it is not an expectation that an individual family member is going to sit down and read the 2,000 pages. And it really just is not the best way to get that individual input. However, I do have to say that the advocates are very good about sending in comments, and I've noticed that the advocates, the patient and family advocates, have become an increasingly stronger voice. And just some of our most recent notice of proposed rulemaking about accountable care organizations, next generation ACOs, integrated care, we got really excellent comments about attribution, about, how are you assigning me to a provider? I want to select my own attribution. I want to pick who you assign me to. Those kinds of things we're starting to hear. So I do believe we are finding a way to get better on that piece of it. And then maybe you can see it on your side. I can't see it here. We are really very intentional in our quality improvement work of ensuring that anyone that works with us also embraces person and family engagement. So you will find in most of our quality technical assistance support contracts, grants, cooperative agreements, there's going to be an expectation that you involve patients and families in your work. Now, we started this really early on. I would say we've always done this in some form or fashion, but the end-stage renal disease networks I think they're in the forefront of this effort, and I'd like for you to take some time throughout this conference to find someone from a network and talk to them about this. We put out a challenge to them. They already had many opportunities with support from CMS. And as a matter of fact, in the audience today, we have Ms. Maggie Carey, who is working with one of our Learning in Action networks. And I asked her if she could just give us a few minutes from a patient's perspective on what this has meant to really embrace this and support it financially as well as from a philosophical perspective.
Thank you, Jean. I really appreciate this opportunity. And if everyone can hear me, I'm going to sit down because the voice is way better than the visual, and I might topple over. I'm privileged to be able to represent the patients here today. I am an ESRD patient, and I come from a generation. I'm the second of 4 generations. My mother, we are a polycystic family, for those of you who are aware of that. My mother died on dialysis back in the 80s. I dialyzed in the 90s. My oldest son started dialysis yesterday, and oh my God, I was cyberspacing with him all morning to get him through his first 4 hours, and it was successful. He's happy today. And his daughter, my 13-year-old granddaughter, is polycystic, so this is her future. So that's my street creds. That's why I know what I'm doing. I am the hugest supporter of the network system out there that you can imagine, because it was the network system that gave me my voice. Back in the 90s when I was dialyzing, the units were not asking for patient voice. That was not in the referendum for those days. But when I stepped into the network world as a patient rep, a PAC rep, it was like Dorothy stepping into Oz. The colors opened up, the Munchkins were singing. I was surrounded by this caregiving team that wanted to know what I thought and how it affected me, and I was surrounded by other patients and could teach me how to do this. From that, with network support and CMS support in the last couple of years, I stepped up and became involved on the national level through the ESRD Forum. And if you don't know about the forum, I could wax poetic for years on that one, but I won't. But the structure is that there are representatives from each of the networks who step up to the forum level and can represent cohesively and cover all of the dynamics, all of the population across the country. And they have the executive director branch, they have the medical branch, and they have the patient branch. And that's what I'm involved with, the KPAC, the Kidney Patient Advisory Council. We represent population and have been getting together monthly, daily at times, to develop products and to bring the patient voice forward. This is what Jean was talking about earlier on responding to these edicts and these ideas that are coming from CMS, and you know, Joe Blow sitting at the desk can't really read that 2,000-page document, but we can. We take it back to our network PACs. Our network PACs take it back to the units, and we're getting voices everywhere, and then bring it back up the chain and bring it to CMS. That's patient engagement. And then very lately, we've been involved, the KPAC has been involved working collaboratively with NCC and their patient land, which my understanding is that's the patient group that has met here in this conference. I mean, ESRD rules. We got a whole room to ourselves all day. I was in a room with warriors, patient warriors, who were celebrating their successful products, brainstorming their issues, and planning for the future. And oh my God, at one point I'm sitting back thinking, these people are juiced. I don't know what they're on, but this is incredible. That's how patients work together when they're engaged. But that brings us to an issue: how do you engage patients? And I've got just a couple quick ideas that I want to share. One, not all patients can be engaged at all times. It's not going to work. There are too many variables in. So if you've got a patient that can't be engaged, don't write them off. Give them the time they need to adjust and come back in 3 months, in 6 months, in a year, whatever. Because as a patient, we've got baggage that is encumbering at best. We have loss, and overriding everything, the video alluded to this, we have fear. The most incredible, crippling fears that you can imagine. Everything you say is filtered through our filtering system. Am I going to die? Is it going to hurt? And am I going to look foolish during the process? So until you can break through that layer, you cannot engage us. Fear manifests in one of two ways. You externalize it or you internalize it. If a patient is externalizing fear, they are angry, they are hostile, they are resentful, they're a pain in your collective butts. That's externalized fear. Internalized fear, harder to identify. They're quiet, they're introverted, they're not making eye contact, and everything is fine. You're not going to get a straight answer from them until you can break through that. There are tips, techniques, there are ways to do it. Once you have broken through that fear and given them comfort, then you have to go to the second step, which is identify their values. Check your values at the door and look to theirs, and don't judge their value system, because you cannot engage a patient until you understand their values, what's important in their life, what achievements they want to make, and it may be contrary to what you're suggesting, but recognize and respect theirs. And at that point, you've got an engaged patient, and you can move on, and they're going to be in a room at a conference juiced, and they're going to change the world for you. Last bit of advice I have is when you are engaging patients at whatever level, in whatever functions that you're in, don't put all your eggs in one basket, because we are a fragile group and you're going to lose some of us. Either to the positive, which is, oh my God, I'm feeling better as a renal patient, I've got a transplant, I'm out of your unit, or I'm able to go back to work, but I've got limited energies, I can't put it here, I've got to put it here. Or you're going to lose us to the downside of life. We're going to be sicker. You're going to bury us. So if you are engaging patients in your projects, have a backup plan, have documentation, have manuals to give to the new person on the block who's stepping forward so that they can come up to speed quickly. Because the sad fact of the matter is you've got an inexhaustible supply of us, but there's pretty high turnover. So I'm going to hold it at that. I know I've got a time limit on this, and thank you for the opportunity.
Maggie. Let's give her a hand. I think we could just about close the session now on that. And we get this kind of feedback all the time, and believe me, we listen, and it's wonderful, it's wonderful. So I just want to quickly go through, I'm not going to spend a lot of time on the other things, but what else do? We pay for care. So even when we're looking at a payment policy, we need to think about the families, the patients that are being served by the policy. On October 9th of 2015, CMS announced a new model application that we're going to look at value-based insurance design models, in which we will be able to look at offering incentives and testing this to see how it works to beneficiaries, looking at cost-sharing options that may be more attractive as we engage in care, and how do we remove some of the barriers that are in regulation or in law that prevent a relationship between patients and families. We're testing those every day to see how we can do that. We weight patient and experience of care in our value-based purchasing programs. We also, in addition to benefit design, we're looking at how we can engage and provide information that patients and families can use. Dr. Conway gave us a challenge at the beginning in January of 2015, just about the end of 2014, and he said, by December of 2015, I want every hospital compare site that we have to have a star rating system, because that's what patients and families tell me they understand, and that's what they want to see. What we have up there right now is not useful to them. And so we looked at him and said, you mean 2017, right? And he said, no, I mean 2015. And so as of December 2015, every one of our compare sites at least has the beginning of a star rating system. And we continue to work with patients and families to see how we can improve that. We are transforming clinical practice initiative. You'll hear more about that. That's a core element of what transformation looks like, and they've been talking about that. Family and caregiver support is extremely important, because we know that the caregiver they help the patient to make decisions. They get them to their appointments. They help them when they get back home to comply. They get tired. They get sick themselves. How do we really support that network? Our Medicaid programs do really a tremendous job of looking at how they can have money follow the person and respite kinds of activities. And we applaud the states that come up with these innovative models that we can certainly learn from those models. So I talked about our CMS affinity group, and we have now about 12 of these groups, people within the agencies that are subject matter experts. They have a passion for a particular topic. They come together to make sure we're communicating, so that someone from the Center for Medicare is talking to the Center for Clinical Standards and Quality, is talking to the Center for Innovation, and is talking to our Center for Medicaid and State Operations. So we're not just all going out doing things without coordinating our efforts. These affinity groups have developed over the past year and have just been a tremendous source of information and knowledge. They continue to grow. We have waiting lists of new groups that want to come on board. But we identify what we call the champion or the leader of the group based on their passion for the topic, based on their knowledge, based on their willingness to take on a tough issue. And most of the time, many times they will self-nominate themselves. Sometimes we approach them, and sometimes they are voluntold, but they really like to be involved. And I identified a champion for the patient and family engagement affinity group about a year ago. And it was probably one of the best decisions that I've ever made because she has just taken it to a new level. And I'm talking about Ms. Janina Wugo, who is the Deputy Director of the Quality Improvement and Innovations Group. And I'd like to bring her forward so she can tell you a little bit about what the group is doing. But when we develop something, we're coming up with definitions of the whole agency can use a patient and family engagement. But we want to make sure that we look at it not just from the policymaker perspective, but how does the family view this? How does the parent view this? How does the caregiver view this? So she's going to give you a perspective on all of that. Let's give her a hand.
Thank you, everyone. For those of you who don't know me, I'm Janini Wuko. I'm sure I'll get to meet many of you, probably not all of you, over the next couple of days. And as Jean said, I am the champion for the CMS Person and Family Engagement efforts. I lead our affinity group for this work, and I'm also leading the development of the Person and Family Engagement strategy for CMS. In this role, as a Deputy Director for Quality Improvement and Innovation, I have a wide range of responsibilities for many of the programs that you all are working on. But my most exciting role, the role that I have the most passion about, is this person and family engagement role. And as Jean mentioned, some people are nominated, some people are voluntold. I don't know exactly how I ended up here, but I wanted to share with you my journey about how my professional and my personal passions at some point over the last few years of my career came into alignment in a way that I didn't predict at all, and I wasn't exactly expecting or looking for. So at the beginning of my federal career, I've been working for the federal government for about 13 years now. And like probably many of my colleagues, I started off fresh out of college. I bought a house. I had a brand new red sports car, which was never dirty. It was always pristine and clean. Nobody ever sat in the back seat. And I was loving life. I was ahead of the curve. My parents were super proud of me. And I had a very, very, very fun life. As you'll see over my talk, over the years, I have become very intimately attached to my work, and the information that you're seeing right now is a family engagement strategy that I'm developing within the agency. Now, I could not, I wasn't able to envision that I would end up here as the champion and CMS policy leader back then. Because when I started as a young professional, this was just work for me. This was my job. I started off working with the beneficiary protection policy. I did QIO regulations. I worked on QIO complaints. I worked on QIO confidentiality work, and it was just what I did from day to day, and my personal life was just kind of separate from that, and I went along like a lot of people do. You end your day and then you go to happy hour as a young professional and do a whole variety of other spontaneous things that I don't do at all anymore. And so in 2010, things changed drastically for me. I got married. My parents both retired, which also gave them a whole lot of time to tell me what path my life should go and what I should do, and all those kind of things that come with retired parents. And I also began to start developing these permanent attachments to things that never existed before. And I didn't know that was the start of a journey that wouldn't end and still hasn't ended at this point. But my work and my life started to align, and it all has kind of come to genesis with me now being a CMS policy leader with this affinity group work, with the strategy development, and also being an internal champion within the agency for patient and family engagement, promoting the policy incorporation into everything that we're doing, and promoting patient and family engagement best practices. So my second role I wanted to share with you as a champion is as a daughter. These are the parents that I talked affectionately about earlier, and they are both retired. They have also taken I won't say taken responsibility. They have taken credit for all of my professional accomplishments, so they are very, very, very proud that I am here in front of 2,000 people today. But in my role as their champion, I found that some of those work fundamentals of person and family engagement have come to life for me. My mother had an episode last year, and we found out that she had a TIA. And so I know a little bit about that. I mean, I know it's kind of a warning for, a potential stroke in the future. And so I'm trying to, tell her what I know. But I'm also kind of getting from her that her confusion over conversations she's had with her doctor, or some liberal licenses she's taken with some of the information that her physician has given to her that I probably would have told her not to take if she talked to me about it before she did that. So part of that experience was me encouraging her to share with her provider her preferences and values. And I actually had to go with her to her follow-up appointment with her primary care physician to say, Mom, do you want to tell your doctor about X, Y, and Z? And you know, doctor, can you please tell my mother the importance of, you know, reducing stress and doing all these things? At the time, my mother was the primary caregiver for my son, and I was telling her, you need to reduce your stress right now. We have to focus on you. This time is about you. We need you to be around. And she's pushing me, and no, I'm going to be there, and Levi's coming every day. And I'm like, okay, I'm going to go with you. Let's discuss this with your doctor. So encouraging, facilitating that dialogue between my mother and her physician was part of my role as daughter and as champion. And then also pushing her and saying, look, I'm losing weight. I had a baby. We all have to lose weight. Let's start to self-manage this. Let's start to talk about it. Let's walk around the mall. We can shop after we walk. Like, I promise you, we will stop at Macy's. But kind of helping her get to improved health outcomes and improved healthcare experience were part of my job as a champion for my mother. And as much as my mother would love to tell all of you that everything I do was to her credit and that she told me to do it, I am taking credit for the changes in her healthcare and the outcomes that she's now been able to achieve because of being a more engaged patient. So the last champion role I want to share with you that I serve is as a mother. At this time last year, my son Levi, the top picture is from this time last year, is from a few weeks ago at a family function. My son Levi was contracted RSV and started having respiratory complications. And so he ended up over a number of weeks in the ICU. He was 6 months old and I was scared to death. And I, was out of work for 7 days, and I was in the hospital. I had my husband shuttling back, clothes and toothbrush and all types of things. And I said, I'm not leaving here, and so he's going with me. And that's because I knew through my work at CMS that he needed a champion, he needed an advocate, and that person was going to be me. And just like this role that I have at CMS, I'm not exactly sure how I was donned as the patient and family engagement leader, person and family engagement leader. Likewise, I'm not exactly sure how out of all the people who were surrounding and loving my son, I was that person who was going to be there 7 non-stop until he left. But I'm happy in both roles. I love both roles. I embody both roles. I embrace both roles. And I also share a journey that many of our panelists are going to talk to you about today. So working with physicians to create healthcare goals, encouraging patients to talk about their fears, asking people to share and to participate in those shared decision-making points in their healthcare are things that we all are doing, even those of us here at CMS as we partner with you. So I'd like to invite our panelists to join me on the stage so we can get to know their journey and hear a little bit about the work that they've done. Thank you.
Any question of why she was selected? I think she answered. We are happy to have Margaret Murphy, Tony Peters, and Jesse Soriano joining us this morning, and we're going to have a panel discussion with them. We're going to ask them a few questions. We're going to open up so that you might be able to ask them some questions as well, or if you have some comments left over from when we started the session that you want to provide, there'll be a few minutes for that as well. I think we have a microphone for you all. Yes. Oh, you're all mic'd up? Great. So thank you all for joining us this morning, and we're really excited to have you here, and as you can see, everybody's excited to hear from you. Maybe you could just start about telling us a little bit about your role and your involvement with person and family engagement.
Sure. So,
and your name, please.
Sure. My name is Margaret Murphy. I'm like Janine. I'm a daughter, a mother, a wife, and a caretaker. I'm also an attorney with the Center for Medicare Advocacy, which is a fishery. So that's what I do professionally.
Thanks. Great.
My name is Jesse Soriano, and currently I'm retired. I've been retired for some years, so I don't work. I just come to things like this. My interest in healthcare and the healthcare system, of course, goes back a long ways. I've been around for a couple of years. 82 to be exact. That's a little bit more precise, I think, than a couple. But my interest in the healthcare system started a long time ago. Noting it, and I've been through several surgeries, not very exciting ones, and also have been my personal health care for a long time. One of the observations I made and have made over the years, and incidentally, all of my training is in education. I'm not in the healthcare professions, actually. Although I spent 12 years at the University of Utah Health Sciences Center as a director of ethnic minority affairs for the Health Sciences Center. The reason I got involved was that I noted that, much to my chagrin, that doctors that I dealt with, no doctor ever invited me to call him by his first name. It always had to be doctor. They could call me by my first name, or they could call my father by his first name. But I couldn't call them by their first names. It had to be doctor. That's still of offending the physicians in the audience. It was also the kind of condescension that you feel coming from doctors and from some of the other healthcare providers. That kind of thing, I think, was one of the first things that I noted as a patient. And so that's led me to a real interest, and as I worked at the university, and I've worked in community groups and with community affairs and with what people call activists, community activists. My interest in disparities, my concern about how some of us, and incidentally, when I say disparities, I'm not talking about my ethnicity. My folks are from Mexico. I was born, I told somebody last night, I was born in a foreign country. I was born in Texas. But in any case, it's not about my ethnicity. It's about, disparity is about how we treat seniors like myself. When I go to the doctor and I say, and I call him Mike, incidentally, and I do that purposely. I say, Mike, this doesn't feel right. His comment is, well, you're getting on. You're getting on in years. That's not an answer for me. So that's a little bit about my background. I worked for state government, federal government for a number of years. I spent a number of years up here in Washington, in Fairfax. And that's disparities. How do we deal with disparities in health care? As I've seen it, my wife and I have been helping an undocumented family from Mexico for some time now. And I've had to take them to emergency. I've had to take them to where the mother had to give birth. I've gone over to translate for them to sort of help them along, understand and navigate the system. So that's, as I say, that's my interest, is disparities. How do we get rid of disparities in healthcare?
Thank you for that. So we're going to come back and have a little bit more discussion about that. But Tony, maybe you could introduce yourself to the audience.
My name is Tony Peters. I am CEO of the Hospital Advisory Committee, and there's a couple of reasons that I am focused on patients. I started in the healthcare field in the emergency room. I worked for a chief of staff at a hospital in business development. I worked for hospice until both my parents decided to go on hospice. You can only do that so many times, but you look at it from a healthcare standpoint, but then I took it from a personal standpoint, from my parents having to be the one to say, hey, physician, you do understand my parents are eligible for hospice, and that was a hard conversation to have. And throughout all the things that have happened, I was able to look at the healthcare perspective, but look at the patient perspective. I think the big thing that hit me one time was when a patient said, Tony, I trusted you, and it fell apart. And that's a hard thing for a healthcare provider to hear. Even though it wasn't my hand that they felt did it, they put their trust in me. So for me to have to go back to the hospital and say, why are you back here? Why'd you make that decision? And to hear them say, I didn't feel safe in the setting was very hard for me. So I took a step back and created my own company to look at how can we take both perceptions and both perspectives. People understand that physicians and insurance companies are not the enemies. They do care. We all have different perspectives, but it's looking at how can I bring the right groups together and the right levels together and say, physicians, this is how your patients feel. Or one thing we are doing in Ohio is educating with the Academy of Medicine and some of the colleges for physicians on what it means to go through each level of care for your patients. And they're going to be using us as a resource to help them understand where each patient is. And I think a key thing, if I could say this real quick, is I think if we could understand where each level fits, how it affects the patient, so that we can be a resource and advocate for them as they go through each journey for their transition. So it's not only a professional desire for me to make a difference, it was a personal experience that I went through, some misdiagnoses. Physicians didn't listen to my mother. She ended up on ICU, and there has to come a point where we have to look at that patient who knows their body, who knows their mind, who knows where they are spiritually, and listen to what they have to say and take that into account along with the education that you have. So if I can walk away, I say every patient, every physician, every healthcare system's not cookie cutter, and we have to remember that these are individuals, and how we go about them is very different sometimes.
Great, thank you. Thank you for that response.
So, Jean talked earlier about this terminology, patient, person, but like you said, Tony, we're all individuals. So maybe Margaret, you can tell us a little bit about how you think that we can work towards ensuring that individuals' preferences, needs, and values are understood and are valued by the healthcare team. Sure.
So in my work at the Center for Medicare Advocacy, which, by the way, medicareadvocacy.org, from a lot of people who are running into problems with the healthcare system. And a lot of times that problem means that they're not getting an individual assessment. There's being rules of thumb are being applied to them. Like Mr. Soriano said, he's 82, and so if you're 82, you don't get more health care, or you don't get therapy, or but people who obviously, he got here from Utah, and there are people who will benefit from therapy. My own grandmother-in-law was in a nursing home. She had been hospitalized in a nursing home, and she was going to go home. We were taking her home. She lived by herself, but there were a lot of family in the area to provide support. And the nursing home, refused to give her therapy on the grounds that she was not going to improve. Well, she was improving, and the goal was to get her home. But even if she wasn't able to improve, she still would have benefited from therapy. And so, there is a case called JIMMO, which says that people can get therapy or skilled nursing to maintain their condition, prevent deterioration. There's still a lot of people who don't know that. And so I would like, the room to understand that Medicare beneficiaries, regardless of their age, may need skilled care, even if they're at end of life and terminal. My dad was terminal, he was on hospice, but he needed therapy to learn to get out of bed with his changed condition. He wasn't going to get better, we knew he was going to die, but he needed to learn how to get out of bed. And so a few therapy sessions helped him with that. And so I would urge, the audience to look at people individually and assess what that individual needs, and don't apply rules of thumb to people just because they're older, or because they're at the end of their life, or they're sick. So that would be my comment.
Mr. Soriano.
I think providers can help patients, their patients manage and understand their own role in the healthcare by doing several things, and these have been repeated, incidentally, in the various sessions and by our speakers yesterday, and it's surprising to me that so many of us here know what needs to be done, and yet the system continues on doing what it's always been doing, or at least that's my perception. And you have to understand that when I speak as a lay person, I have a limited perception of what goes on in the total healthcare system, which is very complicated. So some of my comments are based on my limited perception, and I know that. And so let me tell you, first of all, I think that providers have to know themselves. They have to understand their own ambitions, their own deficiencies before. You have to know yourself. Before I make comments about someone, or before I deal with someone, I have to know something about them, but I have to understand myself. Why do I see them that way? Why do I understand them that way? That's very hard to do. Some of us don't like to admit our own shortcomings. Secondly, the providers have to speak the language of the patients. I'm not suggesting, incidentally, that you have to speak Spanish to deal with me. I'm a fluent Spanish speaker as well, and a couple of other languages. But what I mean is, talk to me in terms that I understand, in English. Doctors speaking to me in English, sometimes I don't understand. So, and that's one of the other things. And third, I mentioned, don't be condescending. Don't speak to me as if I were someone who knows less than you do. I noticed in the video that we saw earlier that the person in role play who's playing the doctor, I don't know if she was a doctor, but she responds to the patient, well, I've gone to school a long time. I've spent a lot of time studying. To me, that sounds defensive. And it also sounds condescending. I know more about it than you do. And you do. As a physician, you do know more about it than your patient may know. On the other hand, there's some things I know more about myself than the doctor knows about me. So those are just some three things that I can come up with.
Thank you. Tony? I spoke to a lot of great points, but looking over how to make sure a patient's goals are met, or number one is see them individually. The other key piece is, one thing we're doing with the hospital is connecting with their social work discharge so we can fully understand what their psychosocial setting is. Sometimes we're so focused on what the medical problem is that we don't understand that there's a lot more issues at home that are going to hinder the follow-through for that patient. So I think creating a whole picture for a patient versus just single outing certain diagnoses or things like that will not only help your team but help that patient understand many factors of what they have to address and what they have to do and what their whole picture is, and putting a care plan together for all the whole picture, not just a diagnosis or something individual.
So I think maybe one more question and then get your questions ready. We're going to come to the audience, but you have a room full of doers, really make a difference. And so what resources or ideas or suggestions would you give to them to be able to leave this conference in action to improve they either provide care or they work with people that provide care?
Do you want me to start? Okay, I'll start with that. If I could say one thing to walk away from is work with your partners, and work with them, but also hold them accountable. When a patient leaves a hospital and goes to a skilled facility, to a home care, I think that each level of care really needs to look at what that next step is, how that's affecting the patient, and follow up on their own. We implement programs like that, follow through. It's easy to say that we're going to do things, but if you can put a true follow through program in place to follow that patient and make sure that they're satisfied with the next level of care versus them readmitting back to hospital, your team, there are many options. I just finished educating physicians that they can bring a patient back within 30 days to a skilled facility. There's so many things that we need to educate across the level of care of the many options and not just patients going back to the emergency room. So I would build a team of partners that you work with and make sure that the patient's aware of every resource, every option they have. And then I would look at your team and your physicians and, look at who's readmitting back to the hospital and start holding your partners accountable for the high level of care and the high aims that you want. You can do that, but if your team's not on board and your partner's not on board, it's going to hinder a little bit. So I just say build a strong team and look at your picture as a whole and build a strong discharge plan for them, because discharge plans are going to be very key for patients.
Thank you.
I think in my experience, I think of when I was at the university, I had a couple of friends, and one of them used to call me up and he'd say, "Jesse, what have you done today? Have you done anything at all? What difference have you made? And why didn't you do this? Why didn't you say that?" And I would say to Mike, I'd say, his name was Michael, I said, "Mike, if you'll pay my mortgage, if you'll take care of my children, and if you'll make sure that I have an income, I'll do all the things you want me to do. But right now, I have a career, I have obligations, I have a responsibility, and I have a loyalty that I owe to my institution." And incidentally, I think that's important to note that most of us in our careers, in our jobs, have to be concerned about our careers and our jobs as we move along. So when I say to people, do something, it's always with the understanding that the something that you do, we've had this discussion. Once you get in a position with an agency, with the government, with an organization, you owe loyalty to that organization or that entity. It would be unethical if you didn't. At the same time, you have to understand the risks that come along with trying to be a change agent. To be a change agent, you have to risk. And I think all of us, and I consider myself, having been working in a healthcare system for a long time now, all of us have to consider that. There's a risk involved in wanting to change the world. And I'm sure that's one of the things that all of us have to understand. So very simply, that's my advice. About your career, that's going to make it difficult for you to bring about some change in the world.
So a couple of other things that I haven't heard is, one, please reach out to the advocates. Somebody mentioned that, I think it was Ms. Moody Williams here that said advocates are giving great feedback on, things in the Federal Register, public comments. But please reach out to us. I can tell you as an understaffed and underfinanced public interest law firm, there are a few others like us, but we are having, it's so hard to keep up, especially with the Affordable Care Act and the new regulations coming out and the new rules. And there are unintended consequences that advocates know about. We talk to people. So please, just even though it's published in the Federal Register, don't assume that we see it. If you see something that's going to affect us and you just want to develop a relationship, please reach out and talk to us. I talk to groups of Medicare beneficiaries all the time. One of the biggest fears that people have is that they don't have an advocate. Either their children aren't close to them, either geographically or emotionally, or they're with a spouse who has cognitive issues, but they don't have that advocate who can be with them in the hospital or help them. So please, reach out, find out who their advocates are. If they don't have one, that's going to be more work for you, but they really need that. And then the last thing I would say would be, sometimes patients are going to challenge you. Sometimes they're going to do a Medicare appeal. Please don't take that personally. Some places, physical therapists will get their back up and say, this is my professional opinion, I'm vested in it. It can go a long way if you talk to the patient and their family and support them in their decision to appeal and to see if, the decision can be changed. changed and but please support them in that. And they fear that you're going to take it personally. They fear there's going to be retribution. Let them know that that's not going to happen and that you're going to work with them.
Thank you. So I want to open up, and if we could get a couple the mics in the audience, and get some questions or comments from you for any of us, and also anything you had left from this morning that you wanted to see. So I see hands over there and a couple over here.
And I'm part of the readmissions initiative. And oftentimes in readmissions, we talk about some of the challenges are based on individuals not having or not knowing about palliative care or advanced directives or hospice. And in a discussion on readmission rounds last week, the patient was still full code, and she had been readmitted 4 times within the past 30 days. How do we have or engage our patients? What would you tell me about what's the best way to engage our patients? Oftentimes, I feel that our physician colleagues are part of the challenge because they're still invested on saving lives. So what could you advise me on?
Sure. I have personal experience with this on both sides of the palliative care issue, and I also see it with patients. I think when you're having that conversation in an emergency or an urgent matter where somebody's, come in through the emergency room, that's a tough conversation to have. I know, with my own father, when he was in hospice for cancer, and he decided that he didn't want additional treatment, and as he said to me, in his last couple of weeks, he said, "Marg, does everybody get this?" And, because he had accepted palliative care and accepted hospice, it was a good ending. My father-in-law, on the other hand, was told by his physician when he was diagnosed with lung cancer that, sure, you'll be able to go to Florida with your wife in 6 months. And so there was a setup of unreasonable expectations. And so that ending was more difficult. It was more difficult for the family. And there was when he ended up in the hospital, and a palliative physician came by and explained what was going on, and that, do you want to go to the ICU or not? And, we helped him decide not to. But then there was another doctor who came in and every day and said, well, what's the treatment? Are we going to try something new? So even in the hospital, that was confusing. And finally, the palliative care doctor had to tell the other doctor to, back off. So, it's a conversation. It has to be honest. It has to be upfront with patients and their families. And it's really important because the ending can, someone's life can be good and it can be meaningful. In my father-in-law's case, there's now disruptions within the family because, there was conflicting information. So I think you're right. You need to get in there early and talk and let people think about it and come back and talk again, and that's all I can say.
I would agree with that. As I travel the country working with caregivers and others, quite often the discussions don't happen early enough, and they don't include the pertinent family members. And so there's the lack of agreement when the decisions have to be made because they haven't discussed that. And one family member says, well, Mom wanted this, and the other one says, well, I thought she wanted this, and there goes the discussion. So thank you. Anyone else?
I just wanted to add for palliative care, I think understanding what that is, that's going to make a little bit difference because palliative care, people look at palliative care hospice like it's a death sentence, but there's also chronic management palliative care, and that's a good way to introduce to patients that you don't have to be on this long term. You're in a chronic situation. We're going to add palliative care, and that is a very soft introduction to palliative care and hospice, and then they can pick up that process and go from there. But a lot of times palliative care is just something that happens right before hospice, but true chronic management palliative care can happen 5 years, it can happen longer, and it can stop and start. So I think if we just relook at what palliative care is for our early patients and kind of softly introduce, that's a good way to get to them. So.
Great, thank you. See, lots of hands. Whoever has the mic, I can't. The light is shining on me. Can't see.
Okay. Adrienne Mims, the Alliant Quality QIO in Georgia, North Carolina. I wanted to that you mentioned in terms of discharge. So we have some standardization in discharge that came from the perspective of the physician or came from the perspective of the pharmacist and the nurse. And I heard you say that there's some components that are missing from a psychosocial arena. I'd love to hear from you what some of those additional components are that we could be adding to the standard discharge.
Sure. I think it starts, number one, it can be, and I work a lot with the post-acute care world, which is your skilled facility, home care, hospice, LTAC, acute rehab, and I also work with the hospitals. And I think, number one, the discharge planning starts when that patient comes to the next level, because one piece that we see is missing when a hospital is discharging a patient, they've already done the whole psychosocial piece. Their social workers have a picture, but we never get that picture to the next level. So we completely start over, and it could be some issues, whether there is behavior issues, whether there's drug issues, whether there's no support, whether there's no meals at home, with a whole big picture that I think sometimes we forget on the discharge, because we want to make sure they got their meds. We want to make sure that they're going to have their doctor's follow-up appointment, which I don't know if the United States, but in Ohio, we have a huge problem with transportation and getting patients back where they need to be on follow-up. So it's looking at all those key pieces and creating a discharge plan for that individual patient with all these different issues they may be facing. And how can we set that up with their healthcare partners, whether someone delivers their medications, their home care company, their hospice. So I'm encouraging in Ohio that when you do that discharge plan, you don't just look at the diagnosis and do they need therapy at home. We need to look at that whole picture. Do they need to be set up with a counselor? Do they need to set up with a psychologist, and different things that, again, it's just taking that whole picture, because nobody wants to have that patient come back within 90 days is the real goal. We say 30, but let's be realistic. How can we keep the patients where they are? And that discharge plan is going to be key. Are you calling your patient to make sure they got to their doctor? Are you calling on, did you like your home care? Did they show up? Because if they didn't show up, that's back on you when you've made that discharge, because the follow-through wasn't there. So that discharge plan has to cover many different things, psychosocial to follow-ups and things like that. And I'm happy to follow up later. I don't want to take a lot of time, but I don't know if my email will be shared, but I'm happy to share things that we're doing in Ohio and some ideas that we're focusing on for that discharge plan.
And I think the important thing to point out when you're talking about that planning is not just when the patient is leaving the hospital. It happens in all of the settings so that you can coordinate the care to avoid, so that the patient can stay in the community or at home or their place of choice. Thank you.
So one other thing we want to do is talk to someone who's used that interactive video that we had at the beginning of the session. We started off the discussion talking about how powerful that was, and Dr. Carol Sinsky, if we can have somebody, Christine Sinsky, and bring a mic to her, I wanted to give her a chance to share how she's used that and how some of the comments that we've heard here today have been used in her work.
Great, thanks so much. So I'm Christine Sinsky, and I'm a practicing internist, and I'm also the PI for the AMA's SAND grant. And I first of all want to thank CMS and the panelists for this wonderful time that we've had together, and the theme of compassion that I've heard. Compassion for patients, compassion for families, and compassion for the caregivers. In fact, one of the themes I want to share is that care of the patient requires care of the provider. And I think that healing relationship that was so emphasized in the video is fundamental to achieving value. That in fact, if we don't have an ecosystem that supports those healing relationships, we aren't going to achieve the value that we're after. Yesterday, Mayo Clinic and the AMA published a study that showed that over 50% of U.S. This is a meaningful career, a meaningful profession, and we are burning our profession, the men and women on whom we rely on, we're burning them out. And this cannot be good for patients, and it can't be good for families. So what can we do? I think it's a shared responsibility. EHR vendors, regulators, policymakers, institutional leaders, we all have a shared responsibility to create the conditions in which patients can get care from nurses and physicians who find joy in their work. And I think that's where we're going to start to move the needle toward getting value. And so very briefly, the AMA is putting together toolkits to help improve joy in practice, because we know that clinical excellence and quality depend on operational efficiency and care team well-being. So thank you very much to the panel. It's been a really important.
This is Carrie to stand, and I'd like for you to see each other. as we did in the video, and maybe have that discussion. And I also wanted people to see you because they couldn't see you before. So we end with a clinician and a patient, and I think that's very appropriate. So thank you all for your time. Let's give our panel another. And I believe we're on to, I'm just going to turn it over to somebody that knows what's next.
Thank you.
Ladies and gentlemen, thank you for joining this session. Because this room is going to be used for another session in just a few minutes, we ask you to please exit the room. Thank you very much.